Good morning, everyone. The clock says 9 o'clock, so we can begin. Thank you very much for making your way here early this morning. I hope you all are caffeinated or have had some oolong tea or whatever you need to be bright-eyed here in the morning air. We're here to talk about something very important today, a troubling prognosis, disparities in race, the racial health gap, and health outcomes. By every measure, including life expectancy, infant mortality, rates of heart disease and cancer, people of color fare worse than white Americans, even when education and income are factored in. It's not about class. Social policies that foster segregation, discriminatory employment and housing practices and inequities in the criminal justice system can all have dire health consequences. Equally powerful is the role of unconscious stereotypes, the way that our mind can trick us, the way that racial bias is sometimes embedded in places that we don't even understand fully. One example, the one that makes people of color who come to emergency rooms with a broken bone less likely, and in fact far less likely, to receive pain medicine than white Americans who show up in similar circumstances. How do we recognize and dismantle health-damaging racism in its many forms? We are here this morning to talk about this. This is a big issue. We only have 1 hour, but we're going to cover a lot of ground. I have Garth Graham, Miriam, Zoila, Pèrez, and Angela Kyodo Williams with me. Angel Kyodo Williams with me. I apologize about that. And I want you each to begin, before I do introductions, with just one line. Help us understand, what do you think is the root of this, the one thing that causes this? Because sometimes we look for the big answers. Those of you who know me know I traffic in 6 words because I try to get people to put a fine point on things. And when you're talking about something as big as this, sometimes it helps just to call out the one thing that you think is most responsible for this. And Angel, I want to begin with you.
That's great.
You don't have to in 6 words, but just briefly, what is the one thing that you think is most responsible?
This America was never built for all of us.
Can you say that again?
This America was never built for all of us.
Okay. Okay. Miriam.
Yeah, I mean, the thing I focus on these days is the pathway between discrimination, stress, and poor health. There's a real strong physiological mechanism that connects those things, particularly when it comes to racism.
And we're going to come back and talk about the stress part, because there's a full body of research that shows that racial factors and racism actually does have real outcomes in terms of stress and health outcomes.
Exactly.
Garth.
Where you live matters. Since the 1940s, the number of zip codes that 80% of African American people live has not changed. And so we have not evolved in terms of where communities live and the concept of equality across communities.
So geography can be destiny when it comes to health.
That's right.
Okay. So you know a little bit about the way they think and the way they see the world. I'm going to work backwards, and I'm going to tell you a little bit about them before we begin our conversation. Does that work? And working backwards. Garth is president of the Aetna Foundation. He's also a cardiologist and associate professor at the University of Connecticut School of Medicine. He served as a deputy assistant secretary in the U.S. Department of Health and Human Services, where he led the Office of Minority Health. Miriam is a writer, doula, and advocate focusing on the unique intersection of race and gender. In 2007, she founded a website called Radical Doula, chronicling her experiences as a queer Latina pro-choice doula and helping found a movement, a full spectrum movement, to bring a compassionate and non-judgmental approach to pregnancy and childbirth support. Angel is a Zen sensei and founder of the senior fellow at the Center for Transformative Change. She is one of only 3 Black women in this role. And is that 3 Black women in this role in the world or in the United States?
Synonymous.
Oh, okay, all right. And she applies wisdom teaching to social issues and is a leading voice for a movement that she has called transformative social change. She is also the author of a book called Being Black, Zen and the Art of Living, and she's also an author of another book titled Radical Dharma, Talking Race, Love, and Liberation. So that's who we have with us this morning to talk about this. And Garth, I want to begin with you because you wrote a really interesting piece in Fortune magazine where you talked about the notion that geography can be destiny in terms of health and how troubled you were by this. And you noted that some of this is not necessarily flattening, but changing. I mean, this used to be something that was quite prevalent in communities of color,
Yeah.
but now you're seeing this among white Americans. For the first time in the United States, middle-class Caucasian children may not live as long as their parents. And you cited this Princeton report. What I appreciate about this is that you brought your whole self to writing about this. You didn't just write about this from a clinical notion, but you talked about this mantra that you say to yourself and what you're trying to do personally as a doctor and as the head of a foundation to challenge this problem.
Yeah, so quite frankly, and a lot of clinicians here and other places understand this concept well. What happens in the doctor's office is not what really drives health outcomes for individuals or communities. It's really all of the factors outside in that community, the housing, education, environment, job opportunities. And so those are the things that we know really drive life expectancy across the nation in all these different communities. So when we take a step back and we start to look at some of these statistics, particularly when it comes to African American communities, we see where over the 171 major cities across the United States, none of those cities have an equality index in terms of where people live. So for the vast majority of our cities, there's a predominance in one direction or another. And that concept, again, like I said before, hasn't changed since the 1940s.
Now, can you just explain what an equality index is?
Yeah, so that's a concept that, where all these communities are either blended or there's a deep separation within communities based on, again, just kind of where people live and the kind of things that they do. And that drives outcomes in a very unique way. So we know that 80% of African Americans get taken care of by 20% of physicians. And that 20% of physicians in a number of different contexts are under-resourced. And so this whole idea of, again, kind of where you live and all of the factors that drive your health outcomes plays out in a variety of different ways. Now, the interesting idea about this, and we'll get into this as we talk further, is there are solutions embedded in this concept, and there are things we can think of in terms of what we can do. But the initial challenge in terms of how I look at it is just this idea that where you live really does drive how long you live.
What are the solutions embedded in this?
Well, so, there's some recent CDC data that came out just this past year that showed that for the first time within the African American community, the life expectancy has been increasing more. Actually, it's a trend that's been going on over the last couple of years. And when you piece apart the data, what you realize is that if you live to the age of 65, if an African American person lives to the age of 65, then the chances of their life expectancy being equal or better than whites is actually pretty good. It's about getting to the age of 65. And then when you look at the kind of interventions that allow people to live that long, you see a vast array of things that deal with, again, housing, education, and dealing with issues around food insecurity. And those kinds of things really are the kinds of things that can move our communities forward. So I like to look at the data and say that we have a lot of challenges, but there's a lot of promise in terms of the kinds of things that we can do.
Miriam, is this possibly because of the services that you are eligible for when you turn 65? Is it that the government steps in or the municipalities step in, that you are eligible for a range of services that you perhaps don't have access to when you're younger?
It's an interesting question. It's actually a new statistic for me, the piece about getting to 65 being sort of a protective factor almost, right? That if you get there, then you get much further. I don't know. I mean, in the work that I focus on, it's about maternal health. And so, I mean, maternal mortality for African-American women is 3 to 4 times higher than white women in the United States. So if you get through the childbearing years, that's a protective factor in itself, right? That's such a huge risk factor for African-American women. So that could also be a piece of it.
So help us understand something, because for women of color, childbirth is itself a risk factor.
A huge risk, yeah.
Why is that the case?
I mean, I think that's the million-dollar question. And I want to say that, it's important to be specific that while women of color as a group do have worse outcomes than white women, if you piece apart that kind of grouping, it's African-American women who have much higher kind of disparity between white women. And then when you talk about Latinas, it depends on what country of origin and how long you've been in the United States. The longer you're in the United States, the worse your health becomes. So I think that's specific.
Wait, say that again. The
Yeah.
longer you're in the United States?
So it's called the immigrant health paradox. And the research shows that the longer you are in the United States, and this is true for Latinas, but also people of African descent who are immigrants to the United States, the worse your health becomes. So I'm the child of Cuban immigrants. I was born in the United States. I'm the first generation to be born here. So my health is likely to be worse than like my grandparents' health was. And so it points to the question of, well, what is it about the United States that's making people sick? And there's people like to talk about things like diet and things like that. I think it's racism, right? And the ways in which people of color are treated differently in the United States, and they might even be treated in their home countries. And so, so that's an important thing to understand and to underpin why I keep coming back to this idea of racism making people sick. And so, with maternal health, I mean, we don't exactly know why, but there's a lot of theories. And where I've landed is this idea, is this pathway that we know is true, that repetitive stress over your lifetime actually has a really strong impact on your health. And even from African American women, there's even research about your telomeres weathering. So it goes all the way to the genetic
So
level.
telomeres, I mean, for those who don't understand that, this is sort of the magic, I don't want to say bullet, but it's understanding this really does help understand health outcomes and what you can do in your own life to make sure that your telomeres are strong and that the ends don't become frayed. And so if you could just take a quick minute to explain.
I might have to pass it to our physician because I'm not.
I mean, do you
not exactly what
I do know.
a telomere is.
So help us
We
out.
want to explain it.
Yeah, so they're the tail ends of certain genes.
Chromosomes.
And chromosomes. And so when those are, they can use them as a measure and understand that if you look at telomere, that basically tells the true life of the person. And so there should be a correlation, but what they can see is that somebody that perhaps is 30 years old may have 45-year-old telomeres. And those telomeres get shortened by a variety of factors, including stress is noticed to be a big factor, and that there are things that we can actually do to lengthen the telomeres or to protect the length of the telomeres. And they're even recognizing that they can actually be grown.
So they can be grown, because that's what I was going to ask,
yes.
because we know that
They
poverty
can be protected and they can be grown.
has such an impact on young people, and that pregnancy has such an impact on women. And those two stressors can really create negative health outcomes, and I imagine that they can really shorten those telomeres and create the fraying on the ends that creates problems. So you can repair that over time.
Yes. I'd love to give you a personal example of what you're talking about. So I have a chronic illness, is lupus. And back in 2012, I had a blood clot, which was a complication of the lupus. I went into the hospital. They basically said, you keep clotting, you're going to have to stay on blood thinners for the rest of your life. But in the process, I saw my blood pressure. And I said, that's really high. It was like 138/90, something like that. And they said, oh, that's common for African Americans. And I was like, but that's not common for me. I hover somewhere around 103 over, maybe 60. And as a result of that, it was December before any doctor, so I was actually getting my blood pressure taken on a weekly basis because of the blood thinners, and I watched it creep up. It was December when it was 157 before they finally listened. Therefore, it took me 3 months additional in order to get a rheumatologist to look at me. By that time, I had stage 4 kidney disease. And it could have stopped had they listened to me in the beginning. Simultaneously, at this moment, and this is a real indication of like how racism works in terms of our health, because of the opioid epidemic, the clinic that I go to now will not prescribe me hydrocodone, which is the only thing that reduces my pain. So I'm in constant stress of pain at this moment because now that white men in particular are experiencing a health epidemic based on opioids, I, as a black woman, can't get them. So I'm
there's
being
no
denied.
path that you can get.
I'm being denied the pain medication now because, and of course, no disrespect, and I certainly want people that are drug addicted and addicted to these drugs to get help. But suddenly they are being withdrawn out of places, and so there is a resistance, even higher resistance, to giving people of color access to drugs that may be the only kind that actually are really supportive for them. And so
there's no way to
stress.
get any kind of waiver or anything like that from your doctor?
You could try.
Okay, and I assume you have.
I have tried, but I want to say, as an empowered black woman, and being in my body and advocating for myself throughout my health, I'm always aware of that low-level tension of having to say, Even when I'm prescribed them, it takes me 4 times as long to use them or 5 times as long to use them. So I'm actually making an excuse and having to say, hey, like in code language, I'm not an abuser just to get them, right? Just to ask for them feels like like I'm stigmatized in the fact of saying, I'm in a lot of pain, these things that you're giving me are not working. And so the stigma is a stressor in and of itself.
So I want to unpack the doctor's office because I think that there's the doctor's visit, because I think that there's a lesson in that. When you presented with elevated blood pressure, the doctor waved that off and said, no worries, that's common among African Americans.
3 doctors.
3 doctors said.
Emergency doctor, general practitioner, and someone, taking my blood pressure for another.
So when you look at the intersection of race and healthcare and the disparities that we see, I'm wondering if you could talk a little bit about the sort of the 2 pathways. So on one hand, is it a case where doctors believe that African Americans or people of color can tolerate more pain, that what seems unusual in the for now majority population is seen as common or acceptable, among people of color? And the other side of that, then the impact of racism and stress. Let's take the first things first because we have an anecdote that actually illustrates this. How do you in medical schools deal with this so that doctors don't make those kinds of conclusions? Do they teach implicit cognition? Are doctors required to go through, and I don't know if any of you have gone through the implicit cognition test. It's very easy to do. You can do it through a website at Harvard. I actually recommend every American needs to do this because you will pull away from the computer the first time you do it and you will say, that cannot possibly be me. And then you do it 2 and you do it 3 and you do it 4 times and you realize that bias lives within all of us for actually good reasons. It's how we survive. You learn you don't drink milk because it's sour. You learn, you cross on a green light and not on a red light. And those same indications can lead to very unfortunate outcomes when it comes to race and assumption.
Yeah, so what you all just spoke about has been widely published, and there's a lot of data that backs up exactly your experience. So Alex Green and the folks at Mass General in Boston have published a lot in the New England Journal and other places around this concept of bias. There's a lot of data that shows certainly many communities are undertreated in terms of pain. Where it gets very challenging is when you look at the data around sickle cell, and you see, a lot of young kids, and older adults with chronic pain who are undertreated, who have a clinical illness that drives that. So there is a lot of studies that have been done, I think, over the past last 10, 15, if not 18 years to really illustrate your personal experience very well. In fact, quite frankly, there's a lot of data that shows that African American communities are undertreated in terms of hypertension for a number of reasons, and in fact, in the broader stressor of things. So I take a step back and I used to think a lot about the problem, and I've started to think a lot more about the solution. And what are the kinds of things, what are the levers that we have known that are evidence-based that can change some of these outcomes? I want to give you an example of what's occurring at Florida International University, a school in South Florida. So what they've done is they take medical students, social workers, and a whole team, and they take care of individual families within communities. So instead of you coming to the doctor's office, they take this team to those individuals' homes. And they treat not just the clinical context, but all of the social issues as well. So they help people apply for jobs. They help connect them with legal aid, as well as a number of other things that we know impact outcomes. And so that is one example of where I see the potential of future medical education going. And the potential of that. And what they did show there, and they'll kind of back it up by data, they showed 13 times, the propensity score is 13 times better in terms of health outcomes for those individuals, but they also showed an improvement in education, housing, as well as other social factors. So what I think is that we know a lot about what the problems are. Challenges, for far too long, we have just accepted these problems as inevitable. We've just assumed that this is the way things have always been. In fact, I think about even some of where I grew up. in South Florida, and I think of some of my friends and some of the things that happen in terms of their own life expectancies being cut short by things that people thought were inevitable. If you look at the zip code that Freddie Gray lived in Baltimore,
Sandtown.
and you look at the fact that the life expectancy within that zip code is pretty akin to life expectancy in many third world countries, the thing that's killing folks there is not violence. It's high blood pressure, diabetes, and all the chronic illnesses that we talked about here today. So when we think about the melding of both the kind of clinical and social factors, that's what I think is driving health outcomes in these communities.
And what is particularly heartbreaking is Sandtown, the neighborhood that Freddie Gray lived in, is just it lives in the shadow of Johns Hopkins.
That's right.
You know,
That's
some of the
right.
best medical
That's right.
care that you could
Sure.
access in the United States.
Sure.
How do you, so what they did at Florida International, it's interesting, they sort of shifted the paradigm. There was something similar that they did at the University of Oklahoma,
Yep.
where they discovered that people who lived in one of 5 zip codes had a life expectancy that was between 9 and 11 years shorter than everyone else in the community. And one of the things that they did at the medical school there is they started to call it the School for Community Health. They didn't really change what they did, but they just started to call it the School for Community Health, the idea that they would insert the word community so doctors would think of themselves as being members of a community as opposed to being almost godlike.
Right.
And administering medicine to all of the people who lived sort of below them.
Right.
But how do you make changes like that when the country is going through such incredible transformation around healthcare, and where people perhaps are, people who could do these kinds of things are perhaps stymied or afraid to make bold changes because they don't know what kind of changes are coming down from Washington that might affect them, might affect their budgets, might affect the sort of protocols and paradigm around medicine?
Well, one of the things we know is that the change from what we call fee-for-service to value-based care, the fact you get reimbursed, per visit as opposed to the overall care of the patient, is changing. And I think that's bipartisan in nature. So as we go to that conceptual model, the idea that the community is what matters is where we have an opportunity to kind of leverage the thinking more in terms of medical school education and how clinicians are trained in general. There's kind of some interesting concepts when you look at how people learn to be a doctor. They're learned to be a doctor not just from what they read and their USMLE scores, it's the mentors and people who they aspire to be. And so one of the things that I do, particularly with my mentees and even others, is try to teach the next generation to understand what it is to take care of not just an individual, but an individual in the context of their community. One of the things from your example that I think is illustrated well, again, everything you described has been backed up by so many different studies, is just this idea that our attitudes matter, and that when we approach patients, what we think and our perceptions do matter. And so, understanding that, that kind of peeling back that envelope, I think is particularly important.
Miriam, is it?
And I just want
Yes,
to
go
lift
ahead.
up that, I absolutely agree with the zip code, right? Like of that location and geography have something to do with it, but to also lift up that then within inside of that, I live in the Berkeley zip code.
Yeah.
And so you can have somebody live inside of a zip code, and then,
That's right.
as you said, individuals' ideas matter inside of that.
Do you dress up when you go to the doctor's office?
Do I dress up?
Do you dress
Yeah,
differently?
pull it together.
And it's funny because I'm just asking this question. Whenever I go to the doctor's, if my mother knows I'm going to the doctor, she will call me. I'll get a call from Betty, and she will say, "No, you're not wearing trousers, are you? You're because she's old-fashioned. You have something nice on, right?" And she's so worried about
That's right.
us being taken seriously when we go to the doctor.
Yeah. How do you present?
How do you present? So she says,
So
don't
they
you
write-
wear those yoga pants to the doctor's office.
Yeah, they write on I've seen my chart, and they write that I'm intelligent and well-spoken. In my chart, and so, it's sort of one, and friendly or something like that. And so it's one of the things I use to my advantage, because to my disadvantage has historically been that I also question what the doctors are saying. That's in my chart too.
So do we need to create bridges particularly in childcare?
Yeah.
Because in some of the studies show that in cases where their home visits.
Yeah.
It makes a difference.
Right.
You know, it makes a difference. In Maryland, they do
Right.
this. In some states, they do this.
Right.
You know, the thing about a doula, she comes to your home. She sees you where you live. You're in
Right.
your space. And when you do that,
Right.
you see certain things. You notice that there's shag carpet. That's going to present a problem when that child gets older if they become asthmatic. You notice that no one smokes in the home, but there's an uncle who spends a lot of time in the home, and he does smoke.
Right.
And so even though the parent says no one smokes, there's still smoke in the house. You notice that there's no books in the house.
Right.
And that can have such an impact if you just suggest that the parent perhaps start buying books for a child.
Unfortunately, I mean, home visiting is not a new concept in the maternal health world. That's been a program that they've been doing for a long time. I mean, I worked when I was in college with a home visiting program in central Pennsylvania in a farm worker community, a mushroom farm worker community. So it's not actually a new tactic, and I don't know that that's actually where I would say we need to go. I mean, I think this model is really interesting, partially because of the education that the doctors get.
That's right.
Like, I think that might actually be more important than what the people. So I want to offer a solution because I think that's really important, and I also want to make the point that the experience that Angel had around idea that hypertension is an inevitability, that like, oh, being black equals hypertension, as if it's a genetic reality, as if it's like this is actually something that this particular race experiences because of their race, rather than understanding, wait, this is an experience that this group of people experiences because of the way people in that race are treated or the conditions in which people in that race live, right? So that's a really important distinction. And I think in maternal health, I mean, I've talked to physicians who accept these statistics about preterm labor, infant mortality, maternal mortality as inevitabilities in communities of color, and that means that they don't actually try to treat them or try to make it be different. And so there's a provider near Orlando, Florida. Her name is Jenny Joseph. She's a midwife. She's a licensed midwife from the UK of African descent, been in the US for a long time, and she's been running a prenatal clinic for 12 years that has had an incredible success at eliminating the negative outcomes we see among African Americans, among the 600 women that she sees every year. And these women deliver in the local hospital, and there's been some studies that have shown, and they've used zip code as a proxy for demographics, so they've compared women in the similar zip codes to her patients who would deliver at the same hospital, different prenatal care, and these women are 3 times more likely, if they don't see Jenny for prenatal care, to have a low birth weight baby, which is an indicator for a lot of other health problems throughout the lifetime, right? If you're born at a low weight, it has a lot of impacts on development. It also can have impacts on the health of the mother, right? There's a low birth weight means perhaps that birth also happened early, which also means that perhaps there was a mechanism that triggered labor early because in a very basic sense, it's like the womb is no longer a safe place for the child, right? So we have to look at things like a skinny baby born too early as a real important health factor, even if the mother survives, even if the baby survives. So what has Jenny done, right? What is it about her model that's been so successful? I mean, one amazing piece of it is that she expects what she calls a chunky baby from every single woman who walks in her clinic, right? She says, you can have a chunky baby. Like you're African American, you're low income, but you can have a chunky baby, right? So not accepting this sort of idea that's inevitable that you're gonna give birth too early, that you're gonna have hypertension during pregnancy, that the kid is not gonna be healthy, right? But she says no, like you can have a chunky baby.
And so how does she get that? Does she talk about nutrition? Does she talk about folic acid? Does she talk about?
I mean, there's a lot of education. A lot of what her model actually does, which is interesting from the physician perspective, is that she's not the top of the chain. So she's the provider, and the other people who are sort of the providers in the context are not the most important person in our model. She sees her receptionist, her clinic educators, her medical assistants as the most important part of her team because they actually spend the most time with her patients. She sees these women for maybe 5 minutes to do sort of the medical assessment, but they spend maybe 2 hours in her clinic. And they sit in the living room, the waiting room, which she calls a living room in disguise, and they have informal chats with a health educator. Sometimes they have group classes where they do prenatal care, they do prenatal education, they chat with each other and have sort of informal support systems. So she's got an amazing model. She calls it the JJ way. I did a TED Talk in October. It's on TED.com, particularly about racism and its impact on maternal health and her model, so you can see more about that. But I mean, I think a big piece of it is that she says you can have a healthy baby. Like you can have a healthy baby. And in a lot of environments where these women walk into, the expectation is that they're not gonna have a healthy baby. And then the other piece of it is just that all of the people who interact with her patients are extremely respectful to the patients, right? They don't chastise them for showing up late to appointments. They don't chastise them if they can't maintain the recommendations that the provider has made because they understand that there's a lot of limitations to nutrition recommendations or whatnot. So I mean, a lot about it is respect, and a lot about it is assuming that yes, you actually can have a healthy baby.
What role does breastfeeding play in this? Because there are all kinds of studies that show that African American women, Latino women to some degree, but really African American women in large numbers are much less likely to breastfeed.
And when you look at that, I mean, you have to look at the pattern of the health system, that there was a time where doctors actually discouraged breastfeeding, right? Just like there was a time when, you know, hospital was best, and now people are sort of moving away from hospitals. But whenever those kinds of swings happen, it tends to be women of color who shift last. They're often the last to be sort of included. So African American women are the last to be included in the hospitals because of racism, and now they're, you know, so you have to look at the historic patterns there, right? I don't actually know how much she emphasizes breastfeeding. I know that prenatal and postnatal care is sort of her model. I assume that it's an important part of, you know, she's a midwife, it's an important part of her model. But when I spent a week there in October, just observing the clinic, and that wasn't a huge emphasis of what we saw.
Angel, what are the cultural roots of this? Why women of color, Black women in particular, African American women, are less likely to breastfeed?
I think that, well, I don't know about breastfeed. I want to say overall, there's a, when we speak history, it's like there's history and then there's history.
Yeah.
And I think that until we really recognize the way in which this country has been incentivized to maintain degraded health amongst Black women, we're not going to really get to the really core issues that shift the way that we think. So I often wonder, like, if we, you know, we're grown people in this country, been through decades of our lives, and we look and we say, okay, here are all these disparities. At some point you have to say, either these disparities exist because these folks are inferior. It just keeps persisting. It's decade after decade after decade after decade. So either they exist because the people themselves are inferior and are keeping themselves in this pattern, or there is something that is keeping them in these systems and this degraded place, right? And if you don't address like the question of like, well, then what is happening? You are left with, I just take it for granted, right? And under I take it for granted is somehow that the people themselves are responsible for it. And I think that we don't say that out loud, but we hold that fundamental belief in this country that everybody's responsible for themselves, that the society has nothing to do.
Part of the healthcare debate right now.
Exactly, right? That society has nothing to do with it. And I think that overall, one of my challenges overall with the ways in which we approach it is we talk about fixing the system, and I think that the system is not broken. I think that the system is working the way that it was intended, the way that it was designed, the way that it was constructed from the beginning of the history of this country. And if we don't begin to unpack that, then the spiritual, fundamental spiritual health and cultural health of the country is what's most in jeopardy, what is most failing, is that we have a fundamental belief system that exists in this country that allows for the continued degradation of certain peoples. And we are not only are we not incentivized as a country, as a nation to address that, this country and nation has been incentivized to actually keep it in place. And if we don't acknowledge that somewhere, as at some piece of our starting point, then we keep treating things as if they're somewhat neutral, that we then have to like move from this neutral place in which people somehow got in poverty. And we should fix it. We should help them fix it.
Like it happened like the weather.
Like it just happened, yeah, right? And just like that over hundreds of years, somehow these people have managed to stay in poverty and stay in these situations. And if we keep approaching it as if it just happened in the last 10 years, 40 years, 50 years, even 100 years, then we're not really addressing the truth of the problem.
So is this, in some ways, when we talk about health disparities, is that a tributary of Black Lives Matter?
Absolutely, absolutely. Because what we're saying in what I think is being articulated in Black Lives Matter, of course, is that in fact Black lives do not matter. They have not mattered. They have not historically mattered. And there's both an assertion of that, and that assertion of Black Lives Matters is a way in which for us to be confronted with the truth that has not been so historically in this country. It remains the truth. Clearly, it's not absolutely everything, but like any challenge. If you don't go to the root of the problem, you keep fooling around with the symptoms, right? And so we can have a war on poverty, but if we don't have a war on white supremacy, then we are not going to address the problem.
So is there, if you take the long game, and it's always smart to take the long view, is there an opportunity for a bit of bipartisanship down the road on this? Because if you look at what's happening, which was noted in the Princeton study and other things, that the rise in deaths of despair among working class and low-income white Americans, the rise in infant mortality rates among low-income children and low-income families. You know, there have been people in Washington who have been beating the drum on this. Many of them are in the Congressional Black Caucus. But you haven't heard voices from working class, from the Rust Belt, from working class America that are taking these issues up. But might they start to do that when they look at what's happening in those communities? And is there a possibility that people might be able to join forces and have the conversation that they need to have to actually address this in a holistic way?
Oh, I definitely think so. You know, my mom taught us, you know, when we were growing up, I used this example yesterday. When we were growing up, my mom took me to a speech therapist because I couldn't speak very well. And she said, well, you know, hopefully your son will be able to graduate high school. And my mom said, you know, asked her about what aspirations she had for her child. She had all these things she wanted her child to do. She wanted to be a physical therapist. And then she said, oh, why can't my kids do that too? And my mom, ever since that moment, it was kind of like a light switch for her that nothing is inevitable. It is not inevitable that I could barely make it to high school. And it was not inevitable that my sisters and brothers would have the same fate as well. And the concept here, and she said this many times, almost a little bit too many times in our life, is that, you know, we can change the things around us if we have a strategy and a plan. And she started back then with this whole thing about amount of words we would learn and this obsession she had with education and schools and looking at where other people were sending their kids and sending us there, even it meant losing an arm and a leg financially. And so when we think about that concept of inevitability, I think about that in my work and in the question that you just asked. There is nothing that we cannot change if we don't have a strategy. Using my mom and another thing she taught us is, but you have to use history as a lesson. You have to look in the rearview mirror to see where you've been going, to get an understanding, to understand where you can go. And so what I'll say is, if you look back historically about where this challenge is, about where we've been through healthcare, you look back at the speeches that were given in the 1900s and the speech that Lyndon Johnson gave in the 1960s when he went to Missouri and signed Medicare and Medicaid into law. You see that there has always been this hope that we have as a country that we can take care of the less fortunate if we come together, right? And so if you look back at that concept, you see where there is a glimmer of hope for us to come together to deal with the issue of disparities. How I see it evolving in the future is that our understanding of disparities continues to evolve. And I'll give you a kind of interesting data point. Our research group has looked at this concept of what defines a disparity population. And what you do see is that many individuals in rural America face a lot of the same challenges that we face in urban America. The same concept of feeling isolated from an economic, a social aspect, housing, and all of these other different challenges. So many of the challenges are particularly relevant. Although I will say, Miriam should speak to this, there is some interesting data when you look at middle-class African-American women and birth outcomes. I'll leave that to Miriam to kind of explain further. So it's not all geography, but that's definitely a component in terms of a lot of similarities. So where do I see the potential for a future? I think all healthcare is local. I think you see a lot of different things happening in a lot of local communities, whether that be in red or blue states where people are looking to try and solve a lot of these problems local. For instance, in Indiana, where they have some of the largest food deserts. We've seen where many local communities come together in Lawrence County, Indiana, to try to tackle the issue of food deserts with urban gardens and working with food pantries and all other kind of innovative ideas. So what I see in terms of the future is looking for local solutions that can build a national vision. I don't believe that all healthcare starts in DC, and I don't even believe that DC is where we'll find all of our solutions. But I do think that there is a path forward in terms of working together.
Everyone's being very calm because it's a bee that's rolling around all of us up here right now. Could you speak, Miriam, to this issue of middle class, childbirth among middle class
Yeah.
women, and where the numbers don't move in the ways you would expect?
I mean, what you said at the beginning, this is not about class, it's about race. And I think geography is a proxy for race in many ways. And at least when it comes to maternal health, low-income whites do better than low-income people of color. So, and then the reverse is also true, that middle-class black women still have worse outcomes than their white counterparts who are middle class. And the gap between middle-class whites and middle-class blacks is actually bigger than the gap between whites and blacks more broadly. So it's
is
not
that
a
because of the
class
zip
issue.
codes that middle-class black women live in, or?
No,
what
I think it's
explains
because of racism. I think it's because of racism. I think it's because of how racism impacts people's health. And that doesn't eliminate, doesn't disappear when you're middle class, that you still experience racism. A lot of the research about looking at discrimination in health, microaggressions, we call them microaggressions, they're not micro at all.
Not micro at
They
all,
have an
exactly.
incredible impact on your health. Every minute that you experience something think about even if you're not a person of color, like when something stressful happens, I don't know, you have to slam on your brakes and not hit the person in front of you, you feel this flood, right? Your heart's racing, you're sweating, like there's this very physiological thing that happens. And that's an important, protective mechanism. But if that happens over and over and over again in your lifespan, it starts to have an impact on your immune system, on your nervous system, on the very specific sort of mechanisms that keep you healthy and alive. And so class is not enough of a factor to eliminate those things. And
I wonder if the word microaggression is problematic.
I think it is. I've been wanting to write about that.
Like
it's not
picayune.
micro. And white folks often ask, well, what can I do, right? What can I do about these problems? And I say, well, if microaggressions have a huge impact on people's health, think about all the times in your day when you're actually the actor of a microaggression. How are you treating the person who's serving you your coffee? How are you treating the person at your school, at your kid's school? How are you treating the person who's cleaning the plates off your table at your restaurant, right? Like all of those little moments and all the implicit bias that goes into the ways in which people disrespect someone, don't act like they're not visible, are rude to them, like that is actually really important. And so it's both upsetting but also amazing that if we could have an impact on lessening the amount of times those things happen to people, we could have a positive impact on their health.
And I'm wondering if there is some correlation between this research and the movement in all of these factors in communities, in low income and working class communities in white America, because there's all these studies show that many people in those communities feel like they are discriminated against.
Right.
They feel that they are
Right.
the victims of bias
Yeah.
in America.
Right. And the research shows that you don't have to actually, it doesn't matter whether you experience discrimination, it matters if you feel like you're being discriminated against when it comes to health impacts. So there's no need to prove were you actually discriminated against? It doesn't matter. If you feel like you experience discrimination, it has a negative impact on your health. So it's true that you don't have to be a person of color necessarily to experience discrimination. It can happen in lots of different instances. And there is, the research does show that white people particularly do feel like they're discriminated against in certain instances.
So in terms of research, we now have an administration that doesn't believe in doing research aggressively. And is this going to be problematic because we're sort of midterm turn in terms of the demographic changes that are happening in America. That page is turning right now. And there are a lot of very important health factors that are tied to the demographic shift. Are we missing an opportunity to do the research that we need the government to do and to lead and to fund in this moment?
Well, as a researcher, I can tell you that we have a lot of research that's already described the problem.
Yeah,
We have, since the 1980s up until 2015, we have, quite frankly, almost hundreds of thousands of articles on health disparities. What we do need more now is the kind of practical research that shows the interventions that make change. Right. And so I think where we are the most challenged now, again, is looking at those examples that are happening out there in communities and elevating that to a point of replicability across the country. So I think we need to move from kind of theory to practicality, from kind of description to strategy, and then moving into this concept of how do we effectuate change. Now, I could be biased, but I'll tell you that, again, I'm not sure that all the solutions are in DC. I spent a lot of time in DC, and I've now spent a lot of time working with local communities, and I see so much happening across the country. I see so much where, young African-American men are going into communities and using even social media and tackling this issue of violence. And when they see a colleague, a family friend, or even someone in their own family who has suffered from violence in local communities, they've done amazing things. I've seen in Kansas City where they are treating violence like a disease and going in and teaching conflict resolution from peer to peer. So there's all these amazing things that I see happening out there that gives me hope that even when I do turn on the TV, I try to remember all of these other kinds of examples that we see.
Don't turn on the TV,
Okay.
just turn on the radio.
Turn the radio. Good enough, good enough.
He works for PBS.
Right, fair.
Let's bring the audience into this discussion. Questions? We can get a microphone.
So to your question about breastfeeding, I would really encourage you to take a look at Jessica Shortall's work. She has a book out, Work, Pump, Repeat. And I don't think it has as much to do with race as you might think. It actually is a structural impediment that women who are trying to go back to work, it's very, very, very hard for them to actually put that into practice. So, and particularly in women of color, they tend to work in wage jobs that are shift work, and those workplaces just do not accommodate trying to breastfeed. So I think it's really a bigger issue of how do we encourage all women to be breastfeeding? What are the environments that we have? And I also wanted to, there was quite a reaction when you made the comment about, in your chart, it said that you were intelligent and well-spoken. So in my practice as a nurse, there are many times when a patient will come in, and I'm looking at those indicators to understand how is it that I can best give my patient education to you? How am I looking at where you are in your mental status and your emotional status today? So just, I love the Open Notes project so that we're looking at them together, and these are my observations that might be able to help the rest of the team to know, where are you today? What level of cognition do you have? Is this a change? What kind of support? So just keep that in mind, that oftentimes those are probably very objective notes that they're making so that they can better serve.
Angel, can you react to that, the possibility that maybe if you came in and you had more of a flattened effect or something, that they would have a benchmark for that? Do you accept that?
Oh, yeah, absolutely. I wasn't suggesting that the notes were inherently bad. What I gathered out of that, though, is that the way in which I was then handled is different, right? And that in and of itself becomes part of the not so microaggression, right? And so it's like I'm like one of the good black people. I'm actually mixed race, and that was part of the problem of like even the way that people were taking me in. But it's like, okay, I'm like a good, and so I'm handled different, and I noticed that I was handled differently, right? And so I benefit from being handled differently in that way. But I don't want my sisters to not be handled that way because they don't speak the King's English the way someone wants them to. And so I totally understand that that's the intention. I think it's rare that things are objective, and I want to say that, and I think that it's mistaken. The other side of that is that in my so-called intelligence and well-spokenness, I was also understood as being belligerent when it came to then following instructions. And so there was a way in which I was circumvented in terms of my treatment and the kind of responsiveness, so that I actually experienced that the doctors kind of like would wave me off. At some point, I actually said to my rheumatologist, he asked me, he said, "Do you have any more questions for me?" And I said, "Yes." And he had to look up because I paused so long. And I said, "Why do you ask me if I have any questions and you don't actually listen to them?" And so this sort of like persistent way of, yes, it can be objective, but like we're shaping people inside of those biases, right? And so there's a set of biases that come along with which I think, and it has to do with, as he said, like the attitude, right? And so I didn't receive that as, that's a negative thing inherently. But I know that then it has an impact on the way that I'm being dealt with, and more important, it has an impact on the way that people that are not as articulate as I am are being dealt with.
And I imagine that if you looked at charts for white patients, it would be very rare to find the term intelligent and well-spoken.
Or articulate.
Or articulate. We know that. That you look at the way the media talks about people. It's just, this is not this is not an unusual example of the ways in which people are described when they're
Yeah, if I had a quarter for every time someone told me, you are very well spoken,
yeah,
as if that's not inevitable.
yeah.
Miriam, could you also take on the question of breastfeeding? Because this beautiful campus was built as a place where business leaders would come and convene, and so there are people here who actually run businesses and make decisions about whether people will have access, women will have access to refrigerators if they're if they're pumping, or a room where they can go and quietly during the day pump breast milk.
Yeah.
The point that women who work in service, women of color often don't work in industries where they have access to those things.
Well, yeah, I mean, you look at, the business environment, so that's like the most elite people are not particularly family friendly. I mean, this is the first year this conference has had childcare. That was the first time, and this is a health conference, right? So, I think it's really important that you look, the standard is terrible for most people. I spoke to TED Women in October, and it was, they had childcare, but you couldn't have your baby with you even in the room where they were screening the talks. And so someone wanted to have a baby with her so she could breastfeed, and she had to be alone in a cloistered room so she could breastfeed away from everyone else. It was a women's conference. It was a TED, what? So, I think, so you look at the most elite and the access is terrible. So it's really difficult to be a working parent and to breastfeed. Paid maternity leave is pretty abhorrent even at the most elite level. So then of course, when you look at folks who are low income and working jobs that don't even support them leaving to give birth, let alone breastfeeding.
So what are the one or two things that would make a difference if you were breastfeeding and returning to work?
I think the main thing is we need to have paid maternity leave. We need to have a good amount of paid maternity leave. The idea that someone has to go back to work after a week or 2 weeks after giving birth is absurd, right? For the health of the parent and the health of the child, just that bonding time. So I think that's, we have to look abroad to the models of really great, generous, universal paid maternity leave, right? That's supported by the government. I think that's number one. And then, I don't have children, so I haven't had the experience of breastfeeding in terms of what makes that, what facilitates that. But there's a lot of things about how the working environment is set up and where people can pump and where they can store it. But I think allowing parents to stay at home as long as possible is really important.
Another question? Michael.
So, we need a mic. Thank you all. I'm Michael Stubbs. I've come from racist and segregated Los Angeles. And, I'm humbled by your grace as we address the subject. And I wonder what can allied and collaborative white people do to change the system to benefit the people who are really, we are all concerned about our health. But when you realize that there are people who are so profoundly disadvantaged, and not to respond with fragility, but really to say, how can we help? What can we do? And that's and how do I not spontaneously combust? And how do you not spontaneously combust with outrage in the moment and in the reality? It's not just stressful, it's just enraging. Thank you.
Because there's too much work to do. I want all three of you to take this question. Angel?
I was on a panel earlier and they were talking about the neuroscience of poverty, and one of the things that I said is that I felt certain in the whole thing about where your zip code is. And so one of the things that I feel clear about, just to answer the second part of your question about why I don't combust, is so I grew up in Tribeca, part of my life, and so that gave me access to horizons and possibilities that if I had stayed with my dad's family in Flatbush, Brooklyn, I felt myself diminishing and disappearing as a human being in the zip code in Flatbush, Brooklyn versus in the zip code of Tribeca. It didn't change the money that I actually had, but it changed my sense of what I could possibly be entitled to, what was possible for me. That was one thing. And one of the things that became possible for me is that I got to choose my own spiritual life. After being an activist for a while and thinking that I couldn't even have a spiritual life. And what I chose was a meditation-based practice and philosophy in my Zen practice. And I feel certain that whatever ways that my hypothalamus was reduced was then increased by my practice of meditation. And so being able to reconcile both the challenges of what I'm facing as a woman of color, a queer woman of color, body, and to both relate to all of that, to take it all in and say, like, all of this is true, that we've had this history. I'm under the gun in this way. Where I am located in terms of society is not exactly high on the totem pole. But that I also seize personal control of my own sense of what is possible for me, what I'm entitled to, and to manage my own sense of personal stress and how I'm going to handle that through the practices that I have in my life is how I don't combust. I think that what white folks can do, I think that what colored folks that are in positions of privilege can do, is we can stop having this, and I know this is not a health conversation, this is a political conversation, but we can stop pretending that this country was made for everyone and begin to think about how do we have a new America in which the design and the construct from the beginning is about all of us, as opposed to continuing to try to fix something that is just not broken. It's working the way that it's supposed to. It is privileging and continuing to privilege certain people. It will continue to do that, and no amount of like taking a wrench to it is going to change that.
It's hard to follow, but and totally real. But I want to talk about my work as a doula really briefly and what that's taught me. How many people here know what a doula is? Yes. Okay. So in case somebody didn't raise their hand, I don't know if I was the only one. A doula is a person trained to provide support to people during pregnancy and childbirth. Not a midwife, not an obstetrician, really a lay person, a support person, kind of a coach. And it's a new idea, but it's not a new concept, right? People, for as long as humans have been alive, have been supporting each other during pregnancy and childbirth. And so the work what that's taught me, and this is backed up by research about the impact of doulas, is that just that act of witnessing someone's experience, honoring it, not trying to change it, just sort of saying, I see you, I support you, whatever you want, whatever you're experiencing is perfectly right and good, has an incredible impact on people's experiences, even just a few hours of that. And I saw that in the work that I did. And so I think about, what does it look like to walk through the world with empathy for people? I don't think our society is built for that at all. But I think that, I think maybe the opposite of a microaggression is empathy. I don't know. That's just sort of a thought I'm having in my head right now. But what does it mean to interact with people and say, I don't know your experience, but I respect it. I don't know your experience. I don't know what's best for anyone but myself, but I want to honor that you're human and that that what you're dealing with is right and fair, and I want to hear that. I think the experience of people of color talking about racism and then having well-meaning white people say, well, I don't know if that's really real, or, right? That's a microaggression too. So trying in those moments to just hear people and say, wow, like, I'm sorry that that's your experience. I'm sorry that's happening to you, right? Rather than trying to sort of talk back to it. I think there's probably lots of ways, even in living in a segregated, privileged environment, where you interact with people who you could treat with more empathy and kindness, and that on a very small level. I live in Washington, D.C. I don't think D.C. is where the answers are. I don't think, especially in this moment, but even during the Obama era, I don't know that was necessarily the hill that we should have been staring at. And so in our daily lives, right, what's the power that we have to really impact the way that we treat each other? And there's just so few experiences in my life that where I get to be treated with respect, and where nobody's trying to change how I feel. They're just trying to hear me and witness me. And even in my interactions with my friends, right, the ways in which I try to do that. So that's this really small thing that can have an impact and really shapes the way I think about how I interact with folks.
Empathy. Before we go to Garth, I would just add, if I can, two things to that. Would be curiosity and proximity.
Right.
To be curious enough to explore someone else's life, and to be, Brian Stevenson talks about the importance of proximity. To actually hear the answer and understand it, you have to get close to someone.
Yeah.
Garth.
Gee, this might get way too personal.
It's okay.
When I think about what my mother did for us, I understand that this concept of full potential for anybody, black, white, of any race or background, is true. So when I think about it, right, so this lady had multiple doctors and therapists tell her that this kid wouldn't graduate high school. Just hang in there. And they weren't even getting into the case. They were more just looking at how we dressed, where we lived, how we, everything about what we looked like and that. From that, I got into college, got into Yale, trained at Harvard, became a cardiologist, worked in policy, worked in DC, right? And I'm able to be sitting in front of all of you having this conversation. And it was that concept that she had, that belief, that core belief, that nothing in life is inevitable. All the advice, all the things you are telling me, that is meaningless because I know the strength of this young kid, you know, this little boy that I have. I know the strength of all these little kids that I have to take care of. Similarly, when I look at what's happening in all of these communities across America, we're facing these challenges. I look at these individuals and I say the same thing about my mother said to us, or it still says, she still says to me, even last night. That still concept of nothing is inevitable. You can do this thing and you can do all of these things. And every little African-American boy, girl, every little Hispanic boy, girl, every little Asian-American boy, girl, every little Caucasian boy, girl can do anything they want. And the evidence I know is because it's in my own life. So I don't have to even think of a hypothetical story. I just look at my own life, and then I look at what happened to other people in our community who didn't have that belief. And I look at people who I correspond with now. I send them stuff in jail. And I go back and forth, and they're still my friends, and they'll always still be my friends. But I do know that truncating their own self-confidence and their own belief in their own who they could be is what ended up in sending them in a path that didn't end up having them allowing and living their full potential. So what keeps me going, other than the fact that I hear from my mother every day, and that I have a 4-year-old and a 2-year-old now that will go on to do amazing things, whatever they decide to do, even if it's medicine, or even if they just decide that one of them wants to be a stay-at-home dad. I know that they will be able to do and live life to their full potential. So all the different things that they can do is how I know that's how I live, and that's how I know that we can make change.
I said we were going to cover a lot of ground in an hour, and we're a little past an hour, so we have to convene. Thank you so much for your time, for your questions. Angel, Miriam, Garth, thank you very much. I hope you were writing a book about your mother.
I know.
Yeah, so-